Good afternoon and a very warm welcome back from the lunch break to all of you. And in the post-lunch session, we will start with the first session that we are going to have is a session on what I did and what I wish I knew then. So to start the proceedings, I would also like to call upon my co-convener, Dr. Harshad Argekar, and I would also like to call upon the chairperson, Dr. Prabhoo.
Good afternoon. It is said that some ideas are so simple that only geniuses can think about them. So we have a panel with us today who are going to share these ideas with us. Simple ideas which they've been using for so long, but they get an epiphany saying that if I had known something about this a few years ago, I would have been able to give better results to my patients. So I'll call the first speaker, an eminent arthroplasty surgeon, Dr. Harish Bhende. He is going to talk about why Charnley was right except for his approach. Also, in the interest of saving a long walk, I request all the panelists to come up here on stage. Please. So Dr. Anil, Dr. Narvekar.
Good afternoon, everybody. I think people are still returning from the lunch, but we have to start with our session. Charnley was right about everything except this, the approach. I actually started my arthroplasty journey in this hospital, KEM, but we didn't do much because we were resident then. Then I went to Sion Hospital as a lecturer, and we had a humongous number of patients, almost split, going over in the corridor also. We had reasonably decent operation theatre, and what we used to do there in Sion Hospital was basically hemiarthroplasties, unipolar, fixed AMR, sometimes bipolar if the patient can afford it, but that was the limit. Once in a while, Dr. Lad will come with his own personal instrument of THR and show us one THR, and that would be, like a big event in our operation theatre. And otherwise, these instruments were basically used to harass the poor MS going students because we knew that they don't know about this, they have never seen about this. But basically with all these arthroplasty we did with the posterior approach, or at least what we call as a Moore's approach or a Southern approach. They were termed in different ways, but we only knew exactly how it is to be done because we saw our senior, and I presume they saw their seniors. Then I went to England, and there was a big transition from theatre, as you see on the left, it was the theatre on the right. And we were all, thoroughly impressed with all facilities which is there. We got exposed to the Charnley's philosophy of hip replacement surgery, trochanteric osteotomy approach, anterolateral approach, Harding's, Liverpool, etc. And then next, actually 4 to 5 years, I was in England. I forgot about posterior approach. Now, Charnley had a big contribution, low friction arthroplasty using polished head with HDP, that is poly-THA, cement in arthroplasty, instrumentation, stages of surgery, infection control with laminar flow system, and obviously a trans-trochanteric approach which was not used by anybody before for doing arthroplasty procedure. But except for all other things, I think the approach is something where Charnley wasn't very right, or at least not relevant today. Now, if you can see why Charnley required this trans-trochanteric tissue damaging approach, because he had only single offset non-modular implant, and he has to treat various sizes of patient. You could have a small tiny guy from Wales. Welsh people are usually small and stocky, while Scottish are usually tall, they call Highlanders, and they are quite big in size. So all these people have to be treated with just one size implant with 140 or 45 offset. So obviously, if you have got a big patient, has a big femur, offset is big in them, and neck length is big. So if you want to use the same implant for all the sizes of bone, obviously you are not going to recreate the anatomy as well. So what Charnley's solution was, in this big femur, you use the implant with a standard fixed 40 or 45 offset. You reduce the offset. Obviously, your abductors are going to be a little weak, and then he would do the trochanteric osteotomy, advance it, lateralize it to balance the abductor. And that's the reason abductors were balanced well, so we don't hear about high risk of dislocation in Charnley because the very small size head which he was used, 22.2 millimeter. Now, this obviously caused three other things. Although the abductors were tightened up, the greater trochanteric anatomy was altered, effective offset is still less than original, and there is always a worry about trochanter going to non-union, the wiring becoming broken, causing pain on the trochanteric area. So these people were unhappy people, and many of them would have some amount of limp if the trochanter is not healed very well. The modern implant are different. We get increasing offset with increasing size, as you can see in coral stem. As the size goes from 8 to 20, the offset progressively increases, which is what it should be in a normal hip. In addition, you also get a high offset implant or a low offset implant. So we can really create an implant which is designed for a particular patient. We don't need to meddle with the trochanter. So we do not need a trochanteric osteotomy just for an approach or even for balancing the abductors. Now, what about other anterolateral approach I saw in England? A lot of people used to use Harding's approach or anterolateral approach. Either you can go in front of the gluteus medius and expose it from the front, but then you can't get a posterior part of acetabulum very well exposed. If there is a posterior part which is damaged, which need to be repaired, you have to go by posterior approach again. Or you can go through the trans-abductor approach, which is Harding's approach. Again, you are going to damage. The approach is limited by the presence of gluteal medial nerve, and that can cause some problem. So that is the reason this approach is, although they had some problem about abductor limb, some pain, discomfort, and not a good exposure in a posterior part or a superior part of acetabulum, I was convinced when I came back from England that in spite of all the issues, still one of the anterior approach is the best, and I used to do that. But then I had an opportunity to go to US, and I spent 1 year with Dr. Ranawat with a proper fellowship, and then I revisited the posterior approach. And I'll tell you what I meant by revisited posterior approach, because he does an approach which is a muscle sparing approach. He repaired the posterior soft tissue very well, and he goes by the anterior small exposure in a difficult cases to get the anterior added opening. I call it tent approach because it explains the mechanism how it happens. Now the so-called posterior approach are actually a multiple approach. It's not a single approach. It was described by Langenbach in 1875, almost 150 years ago. Then Cocker in 1892, Dumont 1887 approached their approaches. Osborne, he was a demonstrator of anatomy in Manchester, showed about another approach in 1952. Gibson in 1950, Murray and Fletcher 1954. Most of these were called posterior approach. There are various ways the posterior muscles were cut, and they were different than each other. The Moore's approach became very famous because of his prosthesis. The self-locking metal hip prosthesis, what we call AMR, became very famous, and this was one of the successful implant for transthoracic fracture neck femur. So his approach became famous, and more started people using so-called Moore's approach, but it is a very inferior approach. It goes between splitting of the lower part of the gluteus maximus, and it's not very good approach for a hip replacement surgery. So many of the time what we have seen in my early days in Sion Hospital was a Moore's approach, which was not ideal for doing a THR because it doesn't give you good acetabular exposure. When I learned 1 year with Dr. Ranawat, the posterior approach was revisited because went through all these things, and we used to discuss all these issues, and the one which I saw was probably the best, which I call tent approach. We go by a posterior approach like this. We expose the posterior flap, then we can remove the head of the femur, and we can approach the acetabulum by pushing the trochanter in the front. If that becomes difficult, you can go in front of the trochanter, release the gluteus minimus only, keeping the gluteus medius intact, and then trochanter can be shifted either behind to look at the acetabulum from the front or in the front and go from behind. So you get a 360-degree exposure of your acetabulum there. With this approach, we can actually do very difficult cases without any problem. A completely enclosed hip with myositis like this can be converted to a THR with a normal anatomy restored back without doing a trochanteric osteotomy. You can do a old dysplastic hip from the childhood with multiple surgeries done and get a normal acetabulum in the normal location with good offset, without again trochanteric osteotomy. We can get an excision hip, which was done 22 years ago, convert that to total hip and create almost a near normal hip in this. Again, we don't need a trochanteric osteotomy in these cases. That's another case with an old infection with fusion, which has been converted to THR, again without getting a trochanteric disturb. We can get a near normal acetabular location and offset and neckline. So basically, to summarize, what I did then was a lot of moves approaches, later on a lot of trans-trochanteric and Harding's approaches, but I really didn't know exactly what was meant by a posterior approach. What I do now and what I wish now is I should have an understanding of a 3D anatomy of the hip joint and understand how the so-called proper posterior muscle sparing approach can be done, so you can create a hip which is near normal, where patient can technically forget that he has a hip joint. Thank you.
Thank you, Dr. Bhende. Dr. Anil Bhatia will talk about his understanding of brachial plexus injury.
Thank you, Harshad, and the organizers of WIROC Grand. I would like to talk about my experience in the management of post-traumatic brachial plexus injuries. These are closed stretching injuries, and as you can see in my database since April 1995, a majority of patients had suffered an injury to all 5 roots of the brachial plexus, and the brain and spinal cord was completely disconnected from the upper limb. Therefore, whatever the patient regained was only due to surgical endeavor. So I prefer to talk about this topic where there is no pre-existing function to mix up the outcome video. But when I started in April 1995, I didn't know that nerves could be approached in this way, the way my teachers taught me in Europe. A particular repair done now, a year and a half later, is going to give this outcome. I had to get that confidence. So I started out with the simplest of procedure, where the spinal accessory nerve is divided distal to its branches to the upper trapezius, and it is bridged by nerve grafts to the musculocutaneous. All of us across the globe are unanimous that the most important function to be restored in a total paralysis is elbow flexion against gravity. So this child was operated on my birthday in 1996, and this was his result. 11-year-old, this was the function. Like day follows night, nerve repairs do give results which we desire, no matter what we try. So I got more and more confidence. So I expanded to getting shoulder and elbow. So this patient was operated in 2002, where I bridged the spinal accessory to the musculocutaneous, used the C5 root that I found ruptured in the interscalene area, and it bridged it with nerve grafts. In those days, for hand function, I wanted sensation. That was a stupid idea. But then I still persisted with that for quite a long time. So I bridged it to the lateral root of median nerve and not the medial root. And I connected 2 intercostals to the triceps. Again, this was foolishness. Using 2 intercostals is like a homeopathic dawai. You need 3 intercostals. But then I didn't know it, I wasn't sure of that at that time. And this was the function. And for a long time, see, as you can see, lateral root of median nerve only gave me flexor carpi radialis. What use is that? So this is what was my target in 2002, to convert a dead weight into a paperweight. I did secondary surgery, derotation, osteotomy, wrist fusion, all that was part of my curriculum at that time. And he came earlier this month, so I have a 20-year follow-up of this patient. But this is something I am ashamed of. In a 20-year-old, only this much function. So as I got more experience, I started using nerve transfers to get shoulder abduction, elbow flexion, elbow extension, and borrowed from the opposite brachial plexus as well to get hand function. And by that time, I realized that you should put it on the medial root of median nerve and not the lateral root of median nerve. But this was the best I could achieve by that formula in a 19-year-old whom I operated in the beginning of 2008. So even after almost 5 years of follow-up, he still needed to force his opposite upper limb in order to produce even that feeble finger flexion on the recipient side. And even at 9 years, the situation was more or less the same. His shoulder and elbow function came as I always expected, but the finger flexion was extremely disappointing. So in my experience, till 2013, using hemi C7 transfer with opposite nerve grafts was completely useless. And I had almost given up the procedure when this publication came out in May 2013, where he describes pulling the lower trunk up and take the whole C7 and repair it to the lower trunk and bring it across the neck in the retroesophageal plane. Now, for an orthopedic surgeon like me to even look at the carotid sheath is a bloody frightening prospect. Here I have to open the normal side, take a full C7, cut it fully, and then push it across the behind the esophagus. So I realized that it has got so many difficulties to get a comprehensive plan to get shoulder abduction, shoulder adduction, elbow flexion, elbow extension, finger extension in a total paralysis. So that was really magic. I couldn't believe my eyes. I saw all these things when I visited Beijing in October 2013. My dear friend Wang Shifeng was very kind to teach me this. Came back, 17th of October 2013, I operated this lady. She had an avulsion of all 5 roots of the right brachial plexus. There is no connection between the brain and spinal cord and the right upper limb. Everything that you're seeing moving has been achieved by nerve reconstruction. And she was able to close the fist and open the fist. And like magic, she could manipulate objects in space. This essentially is prehension. That a person who has got a completely dead limb by his side, without any help from the opposite side, can move objects from one place to another using just the outcomes of nerve reconstruction. That is our objective in the 21st century. So I have persisted with that. So that was in 2013. This is a patient I operated in the middle of lockdown in May 2020. Exactly the same formula. What is amazing in this particular set of videos is that he's using strength from the opposite side for the elbow flexion and finger flexion, the phrenic nerve for the triceps. And while he is flexing the elbow, he is able to do what he likes with the opposite upper limb. Therefore, it is not as if that he is pulling his opposite upper limb in order to activate this elbow flexion and finger flexion. And therefore, he runs a chemist shop. He is able to manipulate objects on his own using the recovered function. And this is not only one case. This is another. Again, similar outcomes. Pulp to palm 0. And again, he can do all that when using the opposite upper limb for other functions. And this is the sort of function that he has achieved in the totally paralyzed right upper limb, completely disconnected from the brain and spinal cord as a result of nerve reconstruction. I'm letting this video run. I know I am well over time. I beg the organizers to allow me to continue. Whatever he is doing with his right hand is purely the result of nerve surgery. In all this, of course, I have aged. So to return and to bring the next generation of Anil Bhatias, we have this collaboration with my pals from Spain, Egypt, and Mexico, where we choose practicing brachial plexus surgeons for exposure to cutting edge surgery of the 21st century, so that they can carry forward what we are doing today. And as I said, I'm not done yet. Thank you very much.
Thank you, Anil. Really a wonderful presentation, almost seminal work on brachial plexus. I now invite Dr. Abhay Narvekar to take his talk on going to the root of the medial meniscus.
Thank you, Dr. Argekar. There are a lot of things that probably I didn't know when I started off. And there are a lot of things that I did very differently then and a lot of things that I do very, very differently now. And I'm sure what I'm doing now is probably much better to the patients. They're getting a better life. Can somebody just open my... Sorry? And I'm sure that we leave behind a legacy for the next generation to do probably much better than what we have been doing at this point of time. I'm not worried. So any questions?
Any questions for the previous speakers? We can have a few questions now. I guess people are anticipating your talk and they're waiting for you to speak. So they're not thinking of any questions now.
Okay. So there is so much that I did very differently when I started off with arthroscopic surgeries in 1985 and 86, and there is so much different that I do now. But I can only pick up one topic because there's so many varied things that I do differently that I just picked up the meniscus and just a small part of the meniscus and would try to get into the root of it. So when we started off, the cardinal principle as proposed by Ian Smiley, all of us knew about the Smiley knives, etc., was that if the meniscus is torn, you not only take it out, but you take it all out. So that was the principle, and that's how we started working. And there was this British surgeon by the name of Blend Sutton, who at that point of time also recommended total meniscectomy. But as we started arthroscopy and we started understanding that the meniscus is probably an important structure, we did what was called as a partial meniscectomy. And you saw that we were very proud in removing these full segment menisci, as one piece. However, a lot of review articles have come since then, and we know that even a long follow-up, such as 21 years, shows you that the incidence of osteoarthrosis is almost increased 14 times the moment you remove even part of that meniscus. So this is another wonderful study of total meniscectomy in adolescents where they compared to the controls, 53 adolescents, 40 years of follow-up, and showed that there is a significant amount of osteoarthrosis the moment you remove that meniscus. So the importance of that meniscus over a period of time was sort of put into our brains. So what we do today is try and conserve as much of the meniscus as possible, even if it is a very complex sort of a tear. And one of the reasons that we are able to do that is probably because of the support that we have with the instrumentation, which has really progressed in these last 35 or 40 years. The meniscus as a substance is not just the part of the meniscus which is important, but probably the root of the meniscus is even more important. And the roots, as you can see, are the posterior as well as the anterior roots of both the menisci. Now here we had a 45-year-old female who had severe pain following just a misstep. And she was not able to walk. She came limping into the consulting room. The diagnosis done at that point of time was a posterior horn radial tear of the meniscus. And the treatment options were only two. Either you conserve it or you do a meniscectomy. We decided to do a conservative treatment, and this was her picture, the X-ray picture of the medial compartment. This is the radial root tear of the meniscus and an associated bone edema because of the loading that occurred because the meniscus was gone. And 6 months later, the woman comes back with continuous pain, but from a medial compartment which was fairly well maintained. In 6 months, she had a total collapse of that compartment, entirely due to the root which was completely avulsed, which we had conserved. So, there were a lot of management options that were available. One of them was a repair. So when we went into literature, you realize that in these cases, if in case you were to repair it, the chances of osteoarthrosis are 53%. But if you were to do a meniscectomy, this went up to almost 100%, 99.3%. And if you conserved it, the chances of OA was 95.1%. So it was necessary to diagnose these posterior horn medial meniscus root tears which come off from the root of the meniscus and basically repair them. So this is the root of the medial meniscus. So you have these wonderful self-retrieving suture devices, so which you can use in order to pass sutures the way you want them. And this is what we are presently doing it, trying to conserve and trying to keep these patients away from arthroplasty as long as is possible. The basic indications for doing this is not only just an MRI picture of a posterior root, but you need to have this tear which is less than 6 months. The extrusion of the meniscus that occurs inherently because the root is gone is less than 5 millimeters. The osteoarthrosis should not be too severe. It should be grade 1 or 2. And the varus should not be significant. It should be less than 50%. But if there is varus along with a root tear, then 2 things can be done. The extrusion of the meniscus can be prevented with an anchor, and the varus is to be corrected with a high tibial osteotomy. So 3 surgeries are done at the same time. So you do a varus correction, you do a root repair, and you put in an anchor to prevent the extrusion of the meniscus. To the next part of the root, we have seen that the overall failure rates of anterior cruciate ligaments, which we were doing concurrently at that time, the reconstruction failures were almost 27%. So in spite of a normal Lachman's, the patients used to be unhappy because there was no rotational control of that knee. And therefore we realized at that point that the posterior root of the lateral meniscus contributes significantly to prevent the pivot of this patient, and ramp lesions also contribute towards the pivoting as well as the posterior medial stability of that. So this is the posterior root of the lateral meniscus. You see that this is completely avulsed, and the treatment for this is almost similar to that of the medial meniscus, where you use this wonderful self-retrieving suture device. You pass it through the posterior portion of that root. You take out a pull-out tunnel and re-anchor it back to where it belongs, providing a significant stability to the secondary restraint to a pivot shift of the knee. The ramp lesion, this is what we mean by a ramp. It is basically a posterior 1/3 capsular region, and it is fairly common, never diagnosed because it is not so well seen on an MRI. It is not even seen on arthroscopy, because when you palpate this, you are basically seeing almost a normal meniscus, unless you were to go into the posterior compartment, where you would find that there is this tear of the posterior capsule just next to the meniscus. And this is what provides a lot of stability posterior-medially as well as for preventing the pivot. And with these wonderful all-inside devices that we have now, we can easily repair this and provide an excellent sort of result to many of these patients. So just taking one particular structure, and that is the meniscus, between 1985 and probably 2022, I think we've taken a very, very long, big step towards providing this particular change from the cardinal principle of if it is torn, take it out and take it all out, to today, you save the meniscus at all costs. Thank you.
Thank you, Narvekar sir. Evolution of meniscal tear, excision to meniscal repair. And I call upon senior most surgeon here, Dr. G.S. Kulkarni sir, talk about an age-old fracture, the intertrochanteric fracture, which we see every day. how has he changed his thought process over the period of years to come to a very important conclusion today?
Unstable intertrochanteric fracture and its importance of lateral wall. If we had started reconstruction of the lateral wall a decade back, we could have avoided many failures of intertrochanteric fractures. Now this is important when there is a instability of the fractures. And what are the unstable fractures? Burst lateral wall, reverse oblique, extension to subtrochanteric fracture, and rare Kyle's fracture, 31A2, 2 and 3, 31A3, 1, 2, 3. There is an exponential rise in incidence of IT fractures. We treat about 150 cases per year, and if we have improved the protocol of the results of the constructing lateral wall, and our results have really improved. Our study, what if lateral wall is not fixed? The pieces are loose and attached to powerful muscles. Therefore, fragments move and cause inflammation, pain, edema, and rarely infection. Cause instability. Elderly patient will not walk till the fragments become sticky. It is true that nail buttresses both lateral and medial wall, but nail will not fix the fragments. They remain loose and cause pain. Fixation of the lateral wall improves the stability, early union, patient walks comfortably, complications are reduced from 9% to 5%. Patient-related outcome is better. We have classified the lateral wall, which has improved and which gives us the line of treatment. The fractures of the greater trochanter, tip, flying GT, which is avulsion of the fragment, and large GT, burst or shattered lateral wall, coronal split, short coronal split restricted to AT area only, long coronal split which is extended to subtrochanteric fracture, banana type which is full banana or a half banana, minimally or undisplaced lateral wall which does not require any fixation. Rare sagittal split also does not require any fixation. See, this is the large greater trochanter and lesser trochanter also. This needs a collinear clamp and cerclage wire to treat both the trochanter, greater trochanter and the lesser trochanter, and a screw, a Powell screw which is this here, this is necessary. Now this is a GT fracture, reverse oblique, lateral wall is shattered, a 4-piece fracture, very unstable. This requires reconstruction of the lateral wall. This is what we call as a Powell screw, which passes from the greater base of the greater trochanter to the lower quadrant of the head, which has good functions. One is it opposes the shearing force, which is this. Two, it crosses it has 2 cross screws which prevent sliding back out. If the screws are parallel, the sliding is more sliding occurs. Thirdly, it increases stability of the construct. This is the burst lateral wall. You can see how the fragments are displaced, and nail alone it will cause rotational instability, and nail alone will not help this. So lateral wall reconstruction is very important by Powell screw and a tension band, and the fracture united nicely. See, here we have used 2 separate bands, one laterally and one medially. Right. A133, nail alone will fail in this case because the head will hang on the nail screw. And lateral reconstruction with the tension band has united. This is the coronal split. We can see the coronal split, short coronal split restricted to the greater trochanter only. And this needs a anteroposterior screw which is inserted percutaneously, and also a tension band which is also done percutaneously. This is a long coronal bridge which is extended to the subtrochanteric area, and this needs a plate and a Powell screw also. Nail plus plate combination is a very good construction, super construction, good function. Banana type. See, this is the banana type, what is the posterior fragment. And the movement that I was talking about is this, these are the movement that occurs, fragment movement occurs. And this needs percutaneous screws, and this needs again reconstruction with anteroposterior screw and a Powell screw. Another case of banana type, similarly treated with good result. Now this is half banana. This is the posterior wall is cut into two parts. This also needs a plate. Now, see, half banana is more dangerous because it is free to move as the iliopsoas muscle pulls it upwards and medially. So it is more dangerous. So this needs a plate as well as a medial tension band wire like this. So plate and circlage wire. Everything is done by percutaneously, and it takes hardly 10 minutes to do all these things. The plate is inserted percutaneously, also the screws are inserted percutaneously, and it gives excellent results. We have published this in injury, augmentation of intramedullary nailing in unstable fractures using circlage wire, lag screws, and tension band wires, a comparative study with and without all reconstruction of the lateral wall. So the take-home message is anatomic reduction, take-home message for the intertrochanteric fractures, which we have during the last 10 years, it have improved the results. The anatomic reduction is necessary, especially anteromedial cortices. There should be a positive reduction. Positive reduction means the head fragment, the beak of the head fragment should be outside the intramedullary canal, outside. So it is medial to the shaft. The tip should not be in the medullary canal. If it is in the medullary canal, it is varus. If it is outside, it becomes valgus, a slight valgus which is necessary. Reconstruct the lateral wall of all unstable fractures. Compress all fragments, reduce and compress all fragments by tension band and lag screws. Prevent postoperative collapse of the head by passing a Powell screw. Add Powell screw and respect TAD. IT fracture will unite with good function if you care of these 5 points. Thank you very much.
Can I invite questions, please? Any questions to sir? There is one question. Sir?
Null. Sir, here.
Can you repeat, Dr. Tiwari?
Sir said that beak should be in the last word, his last mentioned word, beak should be outside the medullary canal.
Yes.
Means medial to distal fragment medial cortex.
Medial shaft.
Medial shaft, yes, I agree. So this is very clearly and confidently said by you to achieve valgus. Is it right?
Yeah, of course.
Yes. Yesterday there was lecture, positive reduction, negative reduction, and Dr. Tanna said that positive reduction means peak should be inside the medullary canal.
No.
That is accepted.
No, yesterday I was there. Tanna has not said like that. Tanna has said it is positive. I was there last time. No,
Okay.
you are.
Okay, it was not a question, so
misunderstood.
he just wanted to have his point of view. Okay, Dr. Binoti, please.
Yeah. So good afternoon, everyone. So a normal carrying angle between the long axis of the arm and forearm of 5 to 15 degrees allows forearm to clear the hips while swinging the arm during walking. When this carrying angle is lost, we call it cubitus varus, and the most important cause for this is malunited supracondylar humerus fractures. Well, the parents bring the children for the cosmetic concern, but I was aware that it leads to some disturbance in hand clearing during gait. That was my only concern in addition to cosmetic, and that is why I used to explain to the relatives. My idea and my outlook to this deformity changed when I came across this wonderful article by O. Driscoll on tardy posterolateral rotatory instability of the elbow due to cubitus varus. In this article, he has nicely explained that with cubitus varus, the whole of the biomechanics of upper limb, the pull of the triceps shifts medially, and this chronic medial overpull leads to lateral collateral ligament stress and lateral collateral ligament attenuation. And this, in future, can lead to posterolateral rotatory instability. So I recommend all of you to read this wonderful article by Kristin Ho, recently published in JPO, where they have mentioned that cubitus varus, it's more than just a crooked arm. And now when the parents present to me, I explain that there are problems with cubitus varus. It's not just cosmetic, but it can lead to snapping of the medial head of triceps. It can lead to tardy ulnar nerve neuropathy, can lead to secondary distal humeral and lateral condyle fractures, AVN of distal humerus epiphysis, and in future can also lead to arthritis of the elbow. So this helps in convincing the parents more and counseling them that this surgery for cubitus varus is essential. So now coming to treatment, cubitus varus, especially when it happens due to malunited supracondylar fracture, is not just varus. In addition to varus in coronal plane, there is hyperextension in the sagittal plane, and there is also internal rotation of the distal fragment. So it's actually a three-dimensional deformity. And we all have learned and we have been practicing this classical French and then modified French osteotomy, which is nothing but a lateral closing wedge osteotomy. Here, as you look at the diagram, it's an osteotomy where the distal cut is parallel to the joint, and the desired angle of correction is marked by another osteotomy proximally. Two screws are passed in the lateral plane, not in the same line, but the distal screw is little anterior. This is done purposely because when the osteotomy is closed, the two screws come in line with the TBW, and that automatically leads to some amount of derotation of the distal fragment. So with this deformity, he tried to correct all the three dimensions by this lateral closing wedge osteotomy. But look at what happens in this. When you just hinge the osteotomy laterally, there is an abnormal lateral condyle prominence, and that becomes a cosmetic concern. There is a very increased and positive lateral condyle prominence index, and though you have radiologically corrected the deformity by improving the humero-ulnar angle, clinically the child may still appear to have a little bit of varus, and this pseudovarus is not very convincing results for the parents. Improvisation on this osteotomy hence happened later on. It was suggested that one should do translation along with angulation to avoid this bony prominence, so as to centralize the shaft over the distal condyles. But by this you are destabilizing the medial cortical hinge and the osteotomy becomes unstable. Step cut osteotomy, it's not advancing, okay. Step cut osteotomy was described later on, where to improvise a spike of the distal fragment was kept laterally, fixed with a screw. This to some extent improved the lateral condyle prominence, but the screw sometimes would break and again make the osteotomy unstable. A three-dimensional correction was planned to be treated more aggressively and nicely by this dome osteotomy, and nice article was published by Tian. But though on paper it looks simple, to implement and execute it on table is difficult in such a small arm. So this osteotomy is not again very technically easy. And then a couple of more osteotomies later came up, like three-dimensional, double dome, pentalateral, just to give a good cosmetic, functional, and stable osteotomy and result in a good outcome. my perspective changed and my practice has changed after this nice article and the procedure details were published of this oblique lateral closing wedge osteotomy in JBJS 2019. A small video which was demonstrated in this article. I think it's, yeah. So in this, a bone model, they have demonstrated an, is it running? Yeah. So a nice small bony model of this particular osteotomy which is described by the authors of this article. So 2 K-wires are passed in the distal fragment just as a joystick which can later be used as a definitive bone fixation. The osteotomy is marked by these 2 K-wires. Now here, as you can see, what is different from the classical French osteotomy is that the distal wire is not parallel to the joint, but it is oblique, starting from the medial epicondyle and going up in an oblique fashion above the olecranon process. Another wire is passed as per the corrections and the calculations which you have made pre-operatively for the set amount of angle which you are going to remove. So this amount of an oblique osteotomy is done. The medial cortical hinge is kept intact. And once you remove this oblique wedge, once you close the osteotomy, the deformity is nicely corrected. There is no lateral prominence in this type of an osteotomy after the osteotomy is closed. And the same K-wires which you have kept as a joystick in the distal fragment, after the osteotomy closure, the same wires can be advanced proximally and can lead as a definitive fixation. If there is any issue about stability of the fixation, an additional 3rd wire can be passed. So as you have seen here, it almost, after the osteotomy is closed, it results in an as normal an elbow as it is, and there is no abnormal lateral condyle prominence. It's a very simple procedure. Simple steps, a lateral incision, osteotomy is marked, you take out the wedge, and once you have corrected, you get on table good correction of cubitus varus. So this is how it looks, fluoroscopy on table, and after correction and after union, a wonderful looking and almost normal looking elbow and with a good correction of cubitus varus. So these are some examples, a simple preoperative planning, and then how you end up with a good result and a good cosmetic correction. So as our theme of Bombay Orthopaedic Society innovations do happen, and now we have 3D models and 3D corrective osteotomies with custom-made templates, and I'm sure in future there'll be more such talks on technology-driven techniques. But till that time, to summarize, cubitus varus is a complex elbow deformity. It's not just a crooked arm. Our understanding has changed after certain biomechanical articles have come up. It has cosmetic as well as functional problems. An ideal corrective osteotomy should be technically easy, effective, and stable. And my practice has changed after doing oblique lateral closing wedge osteotomy, where with meticulous planning and effective execution, I can get a good outcome. Thank you so much.
Thank you, madam. It was an excellent presentation. Can I ask one question? In the video that you showed, the osteotomy in the last, how did you take care of the rotation?
Yeah, so whenever, see the rotational component is actually minor, but when you are closing the osteotomy, you can, to small amount, you can correct the rotation. Also, if you have an extension deformity, you take cut such that the anterior portion of the osteotomy, you are removing more wedge, so the wires are little oblique. So you can modify your osteotomy based on the amount of deformity.
So is it the preoperative planning or it is on the table that you think about?
Preoperative also. Preoperative.
Okay. Yeah. So thank you. Any questions from the house?
Thank you, sir.
Thank you very much. Oh, I'm sorry to ask. Okay. So can I invite Dr. Mihir, Bapat to talk about minimally invasive techniques now, what they have learned over a period of time?
Yeah, so when we talk about lumbar fusions, this is what we have been which we have been doing for the last about 30-40 years. That means you take big incisions, you open up the muscles, allow your visual impressions to get into place, identify your anatomy, and try to correct the pathology to the best possible extent as possible. This has really worked. That means that even now you see your own follow-ups of 20 years and 30 years and you wonder, why do you need to change? So that's about it. So I think it's really about compassion for the patient, and we need to understand that we need to change our strategies as we become more and more experienced, and that is what is called as becoming wiser. So if you see this 92-year-old, now most often in the past, when you used to see patients more than 80, you used to tell them, abhi kya surgery karke fayda hai? So if you see this 92-year-old who used to walk about 2 kilometers till the date where she became bedridden. So she was operated about 10 months back for a laminectomy, and you can see the large scars behind her back. She did improve for about 10 months and then became bedridden again. And now she was facing another surgery. So this is what we ended up doing. So that ruler actually shows the old scar. And what we see in the middle is the actual extent of the surgery now. And this allowed her to come out of bed almost on the same day. And we could make her start walking. So really experience is not something that you gather as the years roll by. It is usually analysis together with literature, together with compassion for your patients, and that is what wisdom is all about. This has been documented very well in literature. So I particularly like the microscopy. So when we talk about listhesis, so these are low-grade listhesis which have been treated with microscopic techniques, and we could do the same thing, give the same result, mobilize the patient much earlier, allowed them to return back to their function within a span of about 2 weeks. So this is what the whole thing is about. Now when you compare the 2 years result down the line, the open results as well as the microscopic results are still the same. So it's that early result of listhesis. Now if you see these cases, now one would believe that really doing a minimally invasive technique for such high-grade listhesis is extremely difficult. But these are now possible, and it is possible to correct your anatomy to as normal as possible, even with minimally invasive techniques which have come into a reality. We have applied it more and more as time went by to low-grade listhesis, to high-grade listhesis, to degenerative scoliosis. And these patients can be mobilized out of bed almost within 24 hours. And there is no reason for these patients to be lying down. The morbidity is much less. The muscle dissection is much less. There are hardly any chances of infections in these patients. Now, it's a simple philosophy that we are kept from our goals not by obstacles, but by a clear path to a lesser goal. So when we accept that this is what I am, and you really don't need to improvise, then that is where you are. And it is all about innovations and clearing the path and using your surgical skills to better and better goals. This was my professor, I think most of us know him, it is Dr. Lahiri. He was the visionary who told me way back 25 years back, Mihir, why are you putting wires and why are you putting hooks? That was the era of hooks and wires. You should put a screw from D1 to S1. And this was 20 years back that a visionary told me that you need to change. And this is where the spine surgery is going towards. Now, he gave me an example. How did he invent a pedicle screw? A pedicle screw for him started when he operated a patient of a disc. That patient went in a bus to his village and came back in the same bus because he had excruciating pain. And out of compassion, he went back to the mortuary and actually invented a pedicle screw to resolve a discitis. So this is how the pedicle screw he started doing. And now we have gone back to minimally invasive techniques. And we have started controlling these pathologies through lesser and lesser approaches. and giving the patients optimal results through minimum approaches. So you see all kinds of pathologies can be dealt with the minimal approachive techniques. Now the pathology says that, look, I am still the same for the past, for the present, and for the future. So when you start assuming that you are the best, the science has always overtaken you. So this is where the whole problem is. And this was a young pilot where we could achieve an osteosynthesis rather than fusing this patient totally, and he could return back to his profession normally. This is a lady who underwent a sacral fracture in one of her degenerative scoliosis, and we could revise it again by a minimally invasive technique. So just allow me 30 seconds. So there is no technique that is absolute. It is an ever-changing scenario. What you know today, you are going to laugh at. 20 years down the line, someone else would be giving the same lecture. So this is how it is. So minimally invasive techniques have evolved into tubular retractors through endoscopies, through various kind of procedures, and we are giving better and better results to our patients. But you have to understand that each technique comes at a cost, and that cost has to be considered while offering that technique to the patient. So there is no technique which is foolproof, and it is the compassion and the patient selection at the end which is going to give the maximum result to the patient. Thank you.
Any questions for Dr. Mihir Bapat? Sir, any closing remarks?
Dr. Mihir, you've been doing spine surgery for the last 25, 30 years. Okay. Since when have you started these minimally invasive procedures?
It's been about 10 to 12 years now.
You have a follow-up?
Yes.
Thank you. So would you advocate or advise the youngsters, spine surgeon, to go ahead and start with the minimal invasive surgery first, or to start with the routine, your age-old procedures, and then later on shift to minimally invasive?
I think the simple thing is that I got the hang of a computer when I was in my third MBBS, but my 7-year-old son knows how to download data from the YouTube. So really allowing people to go back to 20 years back, learn the same procedure of open surgery and go to minimally invasive surgery is taking them back. So if science has advanced to a particular level, everyone should advance above that. So they can learn the minimally invasive techniques and go back and learn the cadaveric dissections wherever they want in the anatomy hall and learn about the anatomy.
Thank you very much. So what do you see as the future? Robotic, navigation, HoloLens?
I think technology is what is changing the world. And in adapting technology, you have to be very careful. There are some technology which are more glamorous, but they don't stand the test of time. There are some technology which are for the future. And whether it is robotic navigation, you have to apply it to each particular patient and try to customize the treatment for that patient. Whatever has happened in the past, all that is shut. It is the next patient that gives you the credit for whatever you are today.
Yeah, so thank you. So with this, we come to the end of this session. We had a mix of all kinds of super specialties here, and we have stalwarts coming to us, starting from Dr. G.S. Kulkarni spoke about IT fractures. Then we have Dr. Anil Bhatia talking about the brachial plexus, Binoti talking about the supracondylar and the Varus deformities at the elbow, Dr. Abhay Narvekar talking about the meniscus repair, which the things have evolved over a period of time. And of course, finally, Dr. Mihir Bapat talking about the minimally invasive surgery in spine. So thank you very much, all the faculties, and we have been really enlightened with your knowledge and your experience.
Thank you. We'll invite for the next session. So the next session is bugs, drugs and implant consideration. In fractures, we have convener Dr. Agashe sir, the chairpersons Dr. Atul Shah and Dr. Anup Agarwal. I invite all the faculty on stage. It's a long walk from the table to the stage.